decides what prescription medication you can use? It's not your doctor. You would think it's my doctor. My doctor decides, but it's actually a middleman called pharmacy benefit managers, or PBMs. They also decide what price you're going to pay and what pharmacy you can fill it at. They have tremendous power. And I'm going to admit something to everybody. A couple years ago, I had no idea what PBMs really were. And they really do great messaging. And they have the public confused. They're saying we're the good guys. The pharmaceutical companies are the bad guys. We're lowering cost. And I honestly was working all the time. I had no idea what was going on. Then when I started doing a deep dive, you can unsee the truth. And that's what we're going to do today. We're going to pull back the curtain, shine the light, and we're going to show you what the truth is about PBMs. And you'll never be able to unsee it again. This is for educational purposes. It's not medical advice. And you should always seek the advice of a physician for your particular needs. When you start thinking about PBMs, you only have to focus really on 3 PBMs. The Big Three PBMs, which is CVS Caremark, Express Scripts International, and OptumRx, control 80% of the market. But it's actually even worse than that, because these aren't standalone companies. These are parts of huge conglomerates that are publicly traded. You have CVS Caremark's part of CVS. You have OptumRx as part of United. And then Express Scripts International is part of Cigna. So these are huge publicly traded groups, lots of power. And they all own insurance companies. They own their own pharmacies that compete with other pharmacies, mail order, specialty pharmacies, and they own physician groups, provider groups. These are huge companies. And the way they use their power is they construct formularies, and that's a list of approved drugs that you can use. And the way they do that, if you're a pharmaceutical company, you have to pay to get on the formulary. So you have to pay to play, and that distorts everything. The other thing that they do, the other power that they do that affects this, is they get to choose how they pay, how much they pay their competitors. Their competitors are independent pharmacies and chains like Walgreens. Now imagine the power if you could say, I can pay my competitors. You literally are holding their life in your hands. You can put them out of business. And this is exactly what's happening all over America all the time. So this is what we're going to talk about today. I have 2 great guests. First, I'm going to go to Brandy Chain, who is an independent pharmacy owner, and she's also a board member of Pharmacists United for Truth and Transparency. And I want to say welcome. Thanks so much, Brandy, for being here. Very exciting.
Thank you. It's very exciting.
And last time I saw Brandy,
great conversation.
Absolutely. And last time I saw Brandy, we were testifying in front of Congress about PBMs, my favorite subject. So we had a great time there. And what I want to ask you, Brandy, is how do you, as an independent pharmacy owner, how do you stay open when you have publicly traded companies coming after you on a daily basis?
You know, it's pretty wild. So whenever you think about the business of pharmacy, 90% of our business is based on prescriptions, whether those are cash prescriptions, whether they go through pharmacy benefit managers. So 90% of our business is where we struggle the most. And you have to, you think about whenever you invest, you have to diversify. Mm-hmm. And for many years, local independent pharmacies was sort of the hub. So if you needed toothpaste, you need toilet paper, think of all the things you can get at a big box store or even a convenience store now. So pharmacies were that hub. Pharmacies are no longer that hub. And we have to find ways all the time to innovate, to diversify our business. And the saddest part of it is that we can no longer do that. We can't sustain this type of business under the current business model. So you see pharmacies closing all the time. And really what it comes down to is you start limiting staff, you start having to turn customers away if you're going to lose money on those prescriptions, because you can't make the decision to serve one patient at the detriment of 20 or 30 other patients. And so ultimately what happens is, you have to make some really hard choices around, can you keep the staff on and can you continue to serve the full patient population? And, that's what it's boiled down to. We have to make those tough decisions every day.
When you fill a prescription, do you know at that time if you're going to make money, any profit on that prescription, or is there fees that come afterwards? Is there audits by the PBMs that affect that?
So we do know at the time that we process a claim. So we get an immediate response that tells us, this is what your gross profit, keep in mind that's gross profit, is going to be. And, lots of times, we're talking, 80 cents, 90 cents, $1, less than $5. I look at these numbers every single day and see, 50% of my prescriptions, I'm going to have a gross profit of less than $5. So that's just the immediate response. And then, like you mentioned, audits. So audits are always something we have to worry about. We have to make sure that we get those days' supplies exactly right. That everything is perfect on that prescription. And we want it to be for safety reasons, but also even just simple clerical errors. A PBM can come in and audit our claims, and they can take back hundreds of thousands of dollars on these audits over simple clerical errors. And so that's where we start to see these predatory audits.
Okay.
There was a law passed, or a rule that was passed that said, DIR fees, direct and indirect remuneration, they have to be visible at the time a claim is processed. Mm-hmm. So used to, they would come back and retroactively impose these fees, and nobody really knew how much they were or what prescriptions they applied to. So now they say you have to see it at the point of sale, meaning when you process that claim. The craziest thing is we still don't know exactly what it is. We just can clearly see what that gross profit is going to be.
That's very challenging. Greg, I wanted to introduce you. Greg Reibold is an attorney, a graduate of Emory Law School, and he is the general counsel for the American Pharmacy Cooperative, and he's also the vice president of health policy. And Greg, thank you so much for being here. Very excited.
Well, thank you. Excited to be here, and big fan of your work and the advocacy work that you've been doing on social media for a long time. So.
Well, thank you so much. Greg and I know each other for a long time on X, and it's always interesting when you actually see the people behind X. So that's exciting. And then could you tell us a little bit about what you do on a day-to-day business with the American Pharmacy Cooperative?
Yeah, so APCI is member-owned by independent pharmacies. We're in about 30 states, and so we are owned by our independent pharmacy members. And my job, general counsel, obviously, sort of contract stuff. Nobody's real interested in that. Not the most exciting part, but focus heavily on sort of the public policy work and trying to advance good, sound public policy on behalf of our independent pharmacy members and of course their member patients. Acute focus on drug pricing, and anytime you're doing work on drug pricing, obviously pharmacy benefit managers and the practices that they engage in are going to factor in centrally, just because they play such a central role in the prescription drug system and sort of patient choice and network access and prices patients pay for drugs, and on and on and on. So I spend, the overwhelming amount of my policy work focusing on practices of pharmacy benefit managers. Before APCI was based out of Georgia and did the advocacy work for the Georgia Pharmacy Association, where we were, very active at the state level in trying to rein in PBM practices. And then prior to that, in private practice, healthcare attorney and litigator, represented all kind of the spectrum of healthcare providers in that capacity. Perfect.
Well, thank you very much. And one of the things that I found out was interesting as I started my journey learning about PBMs is the rebates, because the way the rebates work is the manufacturers pay the rebates, but they pay them to the PBMs, and that's what's called the plan sponsors. Now, plan sponsors are actually the people paying the bill. So it could be a union, it could be a government, it could be an employer. And logically, if I was a sponsor, I would say, I don't want a rebate, I want a discount. Discount is paid right away. So, with the rebate, you pay $100 up front, and then somewhere down the line, maybe you get a rebate. I would say, if you're going to get a $40 rebate, I'd rather get a $40 discount, and there's nothing to chase. But you have this magic rebate. And could you please explain, Greg, how that works? Because a rebate is a kickback. And as a physician under a government program, if I take a kickback, I'm probably going to prison. But yet these people aren't going to prison. So how does that work?
So first, glad you brought it up, right? And I healthcare is amongst the most regulated industry in the country, in the world, in the history of the world, right? Like you as a physician, pharmacy owners, like subject to incredible regulations, and physicians, I would say even in particular when you start talking about like the Stark Law, and sort of a lot of these things, and which the theoretically Stark Law is, hey, no self-interested transactions. That's sort of the theory of it, right? Cool. Pharmacy benefit managers and their affiliated insurers have taken the art of self-interested transaction and implemented it on the grandest scale, right, that you could imagine. And so, whether it's passing rebates back to themselves, to their affiliated insurers, diverting rebates to pharmacies that they own. But, you cut to the quick of it, right? Your question about rebates, because rebates is a $1 billion game, right? Patients pay copays and cost shares based on sort of the price that they pay at the pharmacy counter. And what is not reflected in that price are discounts that drug manufacturers pay to PBMs for essentially formulary placement, right? If you want our patients to, or the beneficiaries under our plan, if you're the health insurer, the PBM, if you want access to our drugs, or to our beneficiaries, if you want your drug to be able to access, you want to be on the formulary, you are going to pay a rebate. How much are these rebates? We've seen rebate examples of 20%. We've seen them as high as 70%, right? 70% of the list price. And so what's happening is patients are paying cost shares, patients are paying copays, patients are paying deductibles, and they're paying that based on sort of the list price or the AWP price of the drug, and they're not paying it on the net price of the drug. And it has become truly a $1 billion game. For context, one of the big numbers that jumped out to me was in a MedPAC report. Brandy, correct me if I'm wrong, I think it was a 2023 MedPAC report. And it found that there were over $50 billion in rebates that Part D beneficiaries didn't get the benefit of at the drug counter, right? Over $50 billion of money that PBMs collected that didn't make their way to the patients. And, from a physician perspective, this is something that doesn't get talked about enough, is there are real world costs to patients paying more at the counter. When a patient overpays for a drug, right, there are implications there with regard to adherence. Obviously, cost is a major driver of medication non-adherence. And then, of course, there are implications there with regard to patient outcomes. And so knowing all of this, right, PBMs and insurers in the Part D market, and also commercial, but they have implemented a system wherein the drug manufacturers are paying those rebates to the PBM or their affiliates, and then where that money goes becomes like a great black box mystery. How much is the PBM keeping? If they say they're passing it back, who are they passing it back to? A lot of the PBMs, to your point, are owned by insurers or own insurers. And so if they're passing the rebates back to a Part D plan, and that Part D plan is owned or affiliated with them, who's keeping that money and what is that money being used for? What we know today is the patient is not getting the benefit of that discount. And patients are overpaying for drugs. They're paying based on like gross prices, not on net prices. And there's all sorts of implications there.
And you're absolutely right. From the physician standpoint, we don't know when our patients aren't getting a refill or filling an initial prescription. Right. And we're just wondering why people are doing so poorly. And one of the FTC reports, the third one they released, which was the lawsuit against the PBMs and their GPOs, talked about that with insulin, where the prices went up 1,200% from 1999 to 2017 for Humalog, the same medication. All of a sudden, it becomes unaffordable. And I talked to somebody who's a lobbyist for one of those companies involved. And in that article, or in that complaint, they talked about a mom whose 26-year-old son died from ketoacidosis, diabetic ketoacidosis, because he had to ration his insulin. And this lobbyist was telling me it was a nightmare with his mom because she kept showing up to all these hearings, Senate hearings, and telling her story. And the senators were like, you know what? We can't even talk to lobbyists because the moms always win. When you have something like that terrible happen, It's awful. But you're right. There's real life effects with this. This isn't a dry policy issue. This is something where people are getting harmed, and the overcharges are phenomenal.
They're absolutely phenomenal. And like, I don't want to get too nuanced on this, but there's so many layers to it, right? Because what we see now is, in connection with formularies, there are instances where PBMs will mandate more expensive brand name drugs when there's a cheaper generic available, right? And so let's say, just argument purposes, and this happens every day. I think Brandy can attest to this, but there may be a $50 generic available. And the PBM, because they're getting a rebate, will mandate that the patient get a $100 medication, the brand name medication. Yeah. And so if you're in a deductible phase and a patient walks into a pharmacy and there's a $50 drug sitting on the shelf, that patient's insurance, and the patient thinks that insurance is there to save them money, right, and cover them. Yeah. Instead of paying for the $50 drug generic that's on the counter, the patient is forced to pay for the more expensive $100 medication that's brand name. If it's in the deductible phase, the PBM isn't paying anything for that. The plan isn't paying anything for that, right? So you've got scenarios where the patient is overpaying $50, the PBM comes out of pocket nothing, and then the PBM actually pockets $50 on the back end. And then we've got scenarios where the pharmacy may have $20 recouped after the fact, right? Via a retroactive fee. We see examples of that all the time. And so you got a situation where the patient forces the patient to overpay for a drug by $50. The PBM comes out of the pocket zero, and they actually made $70 on the transaction, right? They have monetized the rebate system in a way that allows them to pad their profits, allows plans to subsidize their plans off of the backs of sick people, which is something coined by 46 Brooklyn, good friend Antonio Chacha, right? Money from sick people. Mm-hmm. And that's the world that we're living in.
Which also gets you, go ahead, Brandy.
I was going to say, so what we hear often, and it's a big selling point from PBMs, is that PBMs, they put drugs on the formulary that are the lowest net cost. So there's a really important distinction to be made there. So it's the lowest net cost to the PBM or the plan sponsor, but it's not the lowest net cost to the patient, which is exactly what Greg is talking about. So it doesn't have anything to do with the lowest net cost to the patient. So it's really important that we understand, whenever we hear, PBMs or lobbyists talk about that, it has nothing to do with the patient.
No, thank you for making that. And I really wanted to bring that up because I think that's the most confusing part. And that's where I always confused before I delved into this, because the PBMs are saying, look, we lower this price. And you didn't realize that they actually raised the list price. That list price is artificial anyway, because they demanded the rebate. You started with a $50 drug. Now it's a $200 drug because they wanted a $100 rebate. That's the part they leave out of the story. And then in the last year that I saw the gross to net bubble, or the difference between the list price and the net price, was $356 billion. So we have this $356 billion of artificial money sloshing around the system that we don't need. Nobody needs that money to be there. And I think one of the things I'd want every patient who's listening is, don't assume ever that your insurance company is there to get you the best deal. Always ask for the cash price. Trust your independent pharmacist and say, listen, that's what insurance is doing. Can you help me out? What are other options for me? Talk to them. And if you're not.
And is there a generic available?
Is there a generic available? Right. What are my options? And I think that's so important. But everybody's been led to believe the insurance company is your best, and they don't even ask. And they get these crazy things. And there was an example in the first FTC report where they were saying that, and it was for Gleevec, the generic Gleevec, where if you went to the non-preferred pharmacy, which was Costco, you could get it for $97 a month. If you went to the preferred pharmacy, Walgreens, you get it for $9,000. And then it was, if you get the preferred home delivery, which they were pushing you hard, they were steering you towards it, it was $19,200. And these poor people, they had no idea.
So love that you just touched on that, right? Because it all fits together like pieces of a puzzle. But I do think if you're a beneficiary, it's fair to think when you slap that insurance card down on the pharmacy counter, you assume, right? You assume that it's going to cover your costs or lower your costs.
Right.
And little do they know that there's,
Exactly.
one of the largest companies on earth on the back end making money on that claim. But what you just touched on, it fits well, right? But it also gets into another issue with vertical integration, which is patient steering, which is obviously something that we see a lot of in the pharmacy space. Again, physicians are prohibited from self-referral, right? But what PBMs have done is they have implemented and designed plans that require patients to fill prescriptions at their pharmacies. A lot of time they're targeting some of the sickest patients amongst us, right? Think cancer patients, lupus patients, HIV patients, arthritis patients, and they are essentially forcing patients through plan design to fill prescriptions at their pharmacies that they own, and they're marking these drugs up just massively. We did a white paper, I think it was last year, and the highest one that we saw, and this was a federal employee health benefit plan, and it was the patients required to get the drug filled at the PBM-Pharmacy. There's no choice, right? They have to get it through PBM mail order pharmacy. It was marked up 47,000%.
Wow.
Over the national average drug acquisition cost, the national index price, and the price that you could fill that prescription at any number of independent pharmacies for cash, right? 47,000% markup. And so they're making money through the rebate game, like you touched on. And then, as you just alluded to, when you start getting into preferred networks and narrow networks that oftentimes are effectively a network of one, the pharmacies that they own, that's their opportunity to just massively hike drug prices up and fill them at the pharmacies that they own. And those patients are effectively captured.
Brandy, can you tell me what's special about specialty drugs?
So that's a great question. So to be fair, there are certainly drugs that need special handling. So let's just be clear on that.
Correct.
There are certainly drugs, that require certain storage parameters or shipping parameters or, special counseling, things like that. But there are a large number of drugs that are classified as specialty drugs. Those are classified by the PBM. There is not a manufacturer designation or an FDA designation of a specialty drug. So this is defined by the PBM. Often those drugs are forced to a specialty mail order pharmacy that is owned by the PBM because they can jack up those prices and they get the most return for their money by having those drugs filled at their owned specialty pharmacy. Now, also to be fair, there are specialty pharmacies that are not owned by PBMs, but there are huge barriers to entry into getting into that market for pharmacies. So there's a high cost for accreditation. There's a high cost just to try to get into it. Then you can become a specialty pharmacy. That doesn't mean that they're going to let you into the specialty network. Mm-hmm. So we've seen that happen, time and time again with pharmacies who, become licensed as a specialty pharmacy, but these PBMs won't approve them in their specialty network. So keep in mind, like if you wanted to so there are so many drugs that are considered special drugs, and it's just a refrigerated drug. It's a drug that years ago we may have dispensed from the pharmacy. Now the PBM can pay a higher price, but the best sort of argument to that is, well, shouldn't insulin be considered special? I mean, there are very important parameters around using it. Mm-hmm. There's monitoring that's required. It needs to be stored in the refrigerator. It can't go above certain temperatures. You can't just have it out on the shelf as an over-the-counter drug, but that's not a drug that they can jack up the price on, your basic insulins. So it's silly is what it is. It's just a money grab.
And then there's the issue of mail order. And this, I know Loretta Bessing's done a great job highlighting that, because you don't have the temperature control. And then,
Right.
the PBMs force you to do mail order. And then she's had so many problems with her son because of the medications, being exposed to extreme heat. So there's that issue and it's fascinating that there really is no regulation about when you do mail order medications about the temperature control in those trucks. They're not refrigerated trucks, so that's another whole issue as you get more and more people forced over to the mail order.
Yeah, absolutely. And I think, I don't think anybody's done better work than Loretta on really drawing attention to sort of the implications to how these things are shipped and how these medicines can be compromised. And these a little bit different than the quote specialty medications, right? These are PBMs are also targeting a lot of the maintenance medications, some of the most commonly dispensed generic medications, that are filled and prescribed and filled every day. And they are often capturing that market through mandatory mail order under the auspices of cost savings. Again, I'm sure you could have a much more I would say technical conversation with Loretta on what the implications are in terms of their shipping practices and how medicines can be compromised. But from a policy perspective, again, what we also find is not only is care being disrupted, right? And that all of a sudden now there's some medications that the patient has to get filled at a mail order pharmacy versus at the retail pharmacy. So you've got that. But what we've also found when we drill down is, guess what? It's actually not saving money. We looked, again, a federal employee health plan. We looked at the 100 most commonly prescribed generic medications, and we found a federal healthcare plan that required after 2 fills, maintenance medications be obtained through a mail order pharmacy. And what we found is on 79 out of the 100 drugs, it was more expensive at the mail order pharmacy. And so the patient had to fill it. Yeah. So
that is crazy.
There's cost implications, there's choice implications, and then of course there's literally health and safety implications with how these things are being shipped and et cetera.
One of the craziest things that I read was the work out of Ohio and with the Medicaid programs and how they started looking into the overcharges. And I believe it was on spread pricing, but it was $250 million a year. And they were able to have a state-run PBM that took that over. And then they were able to have a more robust Medicaid program because they captured all this money that was just wasted. And then you have companies like Centene, which I think is up to almost $1 billion that they've paid 18 states for overcharging. I think most of that's through spread pricing. This is a crazy amount of money. And obviously, this is harming people, the most vulnerable people who are on Medicaid that desperately need that. And it's also putting independent pharmacies out of business in rural areas. And it's crazy that, we're just discovering all this Medicaid fraud all over the country. But I don't think anybody's really addressed. $1 billion is huge. If as a physician you did anything that was considered Medicaid fraud, they're very aggressive and coming after you, which they should. But, they seem to just look the other way with these huge corporations.
Yeah. And what I think about this a lot because I completely agree, right? Like and just when I was in private practice, I had a healthcare provider that offered like new patients. Literally, they also owned like a little next door. They had a little grill and they offered new patients just free cheeseburger. You would think that like the biggest fraud of the century was being perpetrated, right? With like the meanwhile, you've got pharmacy benefit managers and insurers, right? Just these massive scales engaging in these self-dealing practices. The one thing that I would say is, these companies are so big that when they implement a practice, as egregious as it may be, they almost normalize it because they're so giant that it becomes institutionalized almost immediately, right? And once something becomes institutionalized, it almost feels normal. And so you talk about Ohio, right? And that was a great catalyst for change in Ohio and also spurred some real reforms in other states as well. And there were efforts at even ending these practices in packages, including this year, right? So it certainly was a catalyst for change. But sometimes I wonder, like, when is that going to be, if you're familiar with like Upton Sinclair's The Jungle, right? And when that book exposed certain practices, it enough was enough, right? There were sweeping changes that happened. But these companies are so big and they do it on such a gigantic scale that things that are really just so contrary to good patient care and so gross become institutionalized. And what is it, like Stalin's one death is a tragedy, a million is a statistic?
Yeah.
We're
Yes.
talking about billions of
Yes.
dollars here,
Yes.
right?
Right.
And patients being denied billions. And it's so easy for that to feel esoteric. But the result is, right, patients are losing choice. Patients are going without medications. Patients are overpaying for medications. Oftentimes the sickest patients or senior citizens who are on a fixed income. And there's just massive real life consequences here. And, if you're a lone provider just trying to do the best you can, be it a physician or a pharmacist, and it's like, you've got all of these sort of eyes watching you. And then PBMs and insurers are just wide out in the open, engaging in these practices on the grandest of scales. It really is amazing when you think about it.
So when you talk about your cheeseburger story, so I believe it's United that they have this monthly card that patients get, and like so much money is loaded onto it where they can go and they can use it towards over-the-counter items. And every time a patient asks me about that, I'm so dumbfounded by it. And in my mind, I'm thinking, don't you think these patients would just rather you lower their premiums? Like, then they can go and use that money however they need to. But instead, they're trying to figure out, can I buy vitamins with this? Can I buy toothpaste with this? Can I buy, what can I buy with this? And then there are a lot of places that don't take them. But it's all in the name of health and wellness and promoting wellness. And these patients are like, I don't want to take any of that. So it's almost forcing them to really waste money on items that they don't want to take or they wouldn't take or are not beneficial to them. It's the craziest thing to me whenever this whole debit card thing that they've put out.
The other thing that affects physicians and patients as well is the utilization management techniques that they use, such as prior authorizations, which is really saying you have to ask permission. And if I see a patient, and this really comes up with rheumatology, oncology, and they know there's one medication that's going to work for that person. And unfortunately, they can't use it unless they get permission. And it's crazy the steps you have to go through that. And this is one tip I learned from Julie Bach's video. And that is, if you get denied, you can get an expedited appeal, and they have to answer that in 72 hours. So the patients can go online and do that themselves and just write it out in very graphic language, why you need that, and demand a 72-hour appeal. So that's something the patients can do, because the physicians' offices get overloaded. They get 40, 50 prior authorizations a week. And then there's a step therapy where somebody needs a certain medication, but they have to fail one or two medications first, while their person obviously is not doing well, and you don't want to take that time. And the thing that really bothers me the most is non-medical switching. And this occurs when you have somebody on a chronic maintenance medication, doing great, right side effect protocol, everything's going well. And the PBM says, no, you can't use that anymore. And we're going to switch you to something else. And this causes lots of patient harm. This should not be allowed. There's no justification for this medically, and no physician would ever do that. If I get a new patient, they said, I've been on this asthma medication for 5 years. I'm not going to, and it works. I'm not going to say, oh, nope, you're switching. Forget that. No, you're going to say,
that
oh,
manufacturer
great.
comes and brings us lunch regularly. We're not going to switch.
Yeah.
Doesn't that bring the conversation full circle though with where you started? Rebates, right?
Absolutely.
Like that's what's driving so much
100%. They want to go to whoever's, you're right. That's the incentive for the whole formulary. Absolutely. To steer people to the higher rebates. And, they start out on those formularies. They start off with the P&T committees, the Pharmacy and Therapeutic Committee first. That's transparent. And behind closed doors, then they have the business guys come in and say, and women, and say, how do we maximize the money we're going to get? You're 100% right.
And so instead of the doctor, physician's clinical judgment, right, driving care, you've got rebate dollars on the back end determining what medications patients can access. That's a pretty sad state of affairs. And it impacts, I don't want to be too bombastic here, but I'd venture to say ultimately it impacts probably almost every American family.
It does. At some point, you're 100% right.
Yeah.
You're 100% right. And the crazy thing is 90% of medications are generic and they're too cheap to insure. The people don't realize some of them cost, common medications cost $4 to $6 for a 90-day supply. So why are we forced to pay insurance to cover these? The average person's paying probably 20% of their insurance premium on prescription drug coverage, sometimes up as high as 27%. That's a massive amount of money. And then you have co-pays and co-insurance on top of that for very, very inexpensive medications for most Americans. And that's the other big scam. And that's one of the 10 essential benefits under Obamacare. I wonder how that got in there. So most people really would be so much better off to not have prescription drug coverage and go to the Davis City Pharmacy and just pay cash.
Listen, a really savvy patient, and we get more and more of them every day. And I love it when they come in and say, here's my deductible. Can we look at my prescriptions for the entire year and use your cash copay card and see what my prescriptions will cost if I were to just use the cash program as opposed to my insurance? I love it when they come in because, this conversation happens more and more every single day. Now, that is a savvy patient, and that's what I hope more patients start to do. Because when you're on these really high deductible plans, you're just on, one or two generic drugs. You are never going to hit that deductible, at least not in your drug coverage.
Right.
And hopefully you won't hit it, on your medical side. Yeah. So go cash shop, ask that price. And then, you take back control, your power as a consumer. I mean, that's really how the free market works, when you can price shop. True.
Yeah, and you get away from essentially PBM's ability to price fix, whether it be brand or generics, because Dr. Leary, to your point, right? Like some of these generics are so cheap, but what we found is that PBMs will manipulate those prices just as much as brand prices for different reasons, right? And so we found, I think one of my favorite was a 3-axis study, and it was, I'm going to butcher the pronunciations, of meloxicam brandy.
Meloxicam, you got it.
Am I saying that right? Okay. Mm-hmm. So had a NADAC of 79 cents. Over a 12-month period, there were 117 different price points from one PBM for this drug. The 117 different price points, one of them was as high as $200. So a patient that was getting their insurance benefits administered through a PBM walked in and paid $200 for a drug that should have cost 79 cents. Anywhere, right? Just that's madness when you start looking at how they manipulate those drug prices.
And that's after paying your premiums. That's a part that we don't even think about. You have to add in the thousands of dollars of premiums and then your copays.
I didn't even think you're absolutely right. Right. On top of the overpaying at the counter, they're, they've got their premiums as well. Yeah. Amazing.
That's all crazy stuff. And then the other thing I'd like to just ask you, Greg, is about the fiduciary responsibility of the self-funded employers, and then how that's a problem when they're working with PBMs that are giving them rebates, sharing the rebates with them. And like you said, that's on the back of the sickest patients.
Yes. And so look, and so much to unpack there, right? But what we're starting to see is there is a trend of some litigation from really employees who are saying, hey, look, as a fiduciary, right, you've got some obligation here. You can't just contract with the giant PBM and stick your head in the ground, right? A patient paying 47,000% for above NADAC for a life-saving drug and losing patient choice isn't acceptable. And so I think we're going to see, I think a lot of this litigation, and again, it's in the very preliminary stages, but I think it's going to absolutely help shape the role employers take, and maybe a more active role in sort of overseeing pharmacy benefits management. I'd also note that we're seeing, this also be a catalyst for federal legislation that would also require PBMs, for example, to also be fiduciaries in certain capacity so that they have some liability, because PBMs love to say, oh, wait a minute, we're not a fiduciary. We got no liability.
Absolutely.
And then employers are like, well, good Lord, we don't know what's going on. And so, if there's a silver lining, right, I do think that some of these patients who are employees really sort of trying to hold employers accountable is actually ultimately going to help shape the role that employers play in picking their benefits and overseeing their benefits. Because, one of the things that I'll say is, if you look under the rock and you find something in one spot, you're going to find it in almost every rock you look, right? It may look a little bit different, but when Ohio discovered their spread pricing games and Medicaid managed care, every state that looked subsequently that had managed care, guess what? They found almost the same thing, right? And
Absolutely.
so, if they're playing the game with one employer, they're likely playing it with as many as they can get away with. And so, I think it's a great opportunity for employers to really take notice of some of these findings, take notice of some of these lawsuits, and take ownership over their responsibility to be good stewards for their employees.
No, that's perfect. I'll just add, NADAC is, and I'm probably going to get this wrong, but it's basically a mechanism where they look at these small pharmacies, independent pharmacies, and they ask them, how much did you pay for a group of drugs on a daily or weekly basis? And then they get a benchmark, is what that is.
Yes, it's a public.
It's an acquisition cost benchmark. And
national average drug acquisition cost.
That's correct.
Perfect.
And it's administered by CMS via its federal contractor, Myers and Stauffer. And again, there are some states that also have benchmarks, but NADAC is a public benchmark that best reflects market prices. And so, when PBMs are saying, "Oh, look at this money we saved," or when they're setting these prices, and you're setting a price at $200 when the NADAC price is 79 cents, right? It goes to show you, oftentimes there's the ability for any payer to achieve substantial savings by utilizing this market-based benchmark for drug pricing purposes. And we're starting to see some real movements there at states as well as at the federal level. Historically, Medicaid fee-for-service programs have used NADAC for the ingredient costs that they pay for a price. And so you may see a 79-cent ingredient cost reimbursement to a pharmacy in Medicaid fee-for-service plus a fair dispensing fee, usually around $10 or $11. And then you may look in Medicaid managed care and see a $200 price for that drug, right? So we're, from a policy perspective, big believers in using sort of market-based indexes for drug pricing and taking the pen out of the hand of the PBMs. If PBMs have proven anything, is that they cannot be trusted to set drug prices. If they're setting drug prices, they're finding a way to manipulate those drug prices, often to the detriment of the beneficiary, often to the detriment of the pharmacy or provider, and in government programs to the detriment of taxpayers as well.
And I will say that the PBMs, especially the big three, are really drivers of a tremendous amount of revenue and profit for their parent companies. For United Health had this disastrous quarter, but OptumRx had a 15% increase in revenue. They're driving this ship. And,
for sure.
For all these big three, it's really the PBMs, which is interesting to me because you look at CVS, it's a huge corporation. They have the largest number, I think it's 9,700 pharmacies. You would think the pharmacies would be driving the ship. It's not. It's the PBM. It's the middleman. And this is where healthcare in the United States has come. This is the problem with healthcare is the people, physicians, pharmacists, anybody who touches a patient, anybody a patient sees gets penalized in the system. The middlemen that are hidden away that patients never see, that's where all their money's going to. That's what people don't understand. And that's what's, like I said, is really driving. That's what's hard to reform the PBMs because these companies push back. It's not only the PBMs pushing back, but their parent companies push back because that's their lifeline. That's keeping United afloat right now is the Optum division.
That's the gravy train.
That's the gravy train. That's a whole thing.
It's such a huge conflict of interest. It goes back to sort of everything we're talking about where, you've got the insurer that owns the PBM, that owns the pharmacy, and then, has an offshore group purchasing organization. I mean, this vertical integration, it's incredible. It has, it is completely out of control. But, when you talk about antitrust implications, we touched on it before, and I use this example all the time whenever I talk to someone who's like, what? This makes no sense to me. So if you have a tire store and you open up and you just want to have, just a simple tire store business, And here you've got big box store down the road saying, well, your customers can only pay this much for their tires, and you can only charge this much, but we will also dictate what kind of tires you can put in your shop. And it's just completely insane to me. And as you look at this, go ahead, Greg.
And oh, by the way, you have to pay for air from us, and air isn't free, right? Like if PBMs were in the tire business, like the tire's $250, the air is $1,000, right? Welcome to the era of PBMs owning tire dealerships.
Right. So, it all ties in. And so this vertical and horizontal consolidation, ultimately there's got to be a breakup. I mean, there has to be a breakup, and go back and look at, the Ma Bell situation. And
absolutely,
I mean, that's one of the most important steps that needs to happen is there's got to be a breakup. And, that also addresses the fiduciary aspect of it to some degree.
And we've seen efforts, right, at the federal level. And matter of fact, Brandy, you and I were in Arkansas together one day. That's right. For the good work that the Arkansas Pharmacy Association and the General Assembly in Arkansas were doing, because they were the first state in the nation to say, hey,
that's right.
In Arkansas, you can be a PBM or you can be a pharmacy, but guess what? You can't be both. And so that was probably one of the most significant pieces of legislation at the state level to pass
ever.
Probably ever, but certainly 2025. And again, I think efforts are continuing in other states and as well as at the federal level to just try to that sort of get at the core of that conflict of interest and say no more and literally break them up.
Right.
No, I agree 100%. There's too many conflicts of interest. And I think bottom line is that we're not putting the patients first with PBMs. Clearly, and they started out as claims processors. That was fine. And then, they had so many mergers. In that first FTC report, and I think it was over like a 4 or 5 year period, there was 88 acquisitions done by Optum. I mean, it's a huge amount.
Wow.
So if you're publicly traded, you have so much money. I mean, United Health has 2,700 subsidiaries, and most of them don't have to be reported because it's such a huge
bank.
They own a bank. I mean, there's so many different things that they do that people don't know. And, 2 of those 3 group purchasing organizations are offshore. So one's in Switzerland, and that's Cigna's is in Switzerland. And then MSR's, which is the Optum one, is in Ireland. And the thing is, I found a footnote, and I love read all these obscure documents. And one of the things is that the contracts with the manufacturer, the rebate contracts, are actually physically in those locations. If you're an employer and if you have Optum RX and you say, I want to see that contract, you have to get on a plane and go to Dublin. You can't see it. You have to physically go there. So it's very interesting.
Well, but then there was just the Hunterbrook report where people actually went to these physical offices, and guess what? Nobody's there.
Nobody's there.
So where are you going?
Exactly. So you're never going to see that contract because nobody's there. So if you got there, no one's there. But
that's nuts. You want to see it? You got to go overseas to see it. The other thing, and
Dublin.
You may have a better handle on this than me, but I've read also that United is at this point like one of the largest employers of physician in the country as well.
They own the largest number, 10% of all physicians, 90,000 physicians are owned by United. And I'm going to say, I'm so glad you brought that up here. Physicians should not be owned by an insurance company, a hospital, or private equity. It's a huge conflict of interest. And when you talk about self-referral, when you're a physician, you're owned by a hospital. What they want you to do is self-refer all day. I'm going to send Mrs. Jones down the hall for the CAT scan that costs $10,000, not across town for $350. Nope. And same thing for the drugs. I'm going to send her outpatient meds there. Her labs are going to be marked up tenfold. It's insane, the markups and the facility fees, whole thing. But no, 100%. But you're right. That's one of the problems with Optum. And then you have the minute clinics with CVS.
But an insurance company is allowed to own a hospital, a physician, all of these channels. But a physician can't even own a hospital.
Nope, can't own a hospital. You can't own. There's so many things that they're worried about self-referral. And the funny, when you look at Stark laws, even if I have a self-referral, if I send a patient somewhere, even if it costs less, even if it's better quality, I still broke the law.
Right.
I mean, it is draconian.
What are you in for? Saving patients money, right? Like
Exactly. I can't say, if I said to a patient, listen, you could go down the hall, I'll do this x-ray for you for, $15. Like, nope, can't do it. So it's under federal programs. And that's why more docs are starting to opt out of Medicare. And I think that's going to be an issue. But I'm going to do is, this has been a great discussion, and I'm going to wrap this up. I think everybody now knows the truth about PBMs. I'm going to ask you each a quick question. Do you think PBMs save patients money on drugs? Yes or no?
No.
Okay. Thank you. That's one of the big talking points. So I'm going to close this up. This has been a great discussion. And for all the viewers, if you found that this was great value, which I think is great value, please like and share. And any comments, let me know in the future topics that you have or any questions that you have. And then please like and follow me also on X and LinkedIn. And thank you again for watching. Thank you for listening to my podcast, the Real Doc Speaks podcast. Please like and subscribe on YouTube if you find this to be valuable content. And you can follow me at LinkedIn and X, as I'm very active on those platforms as well. And please let me know if you have any questions and have any suggestions for future topics. Thank you again.